First of all, I would like to thank the organizer to invite me. I take it a kind of a special privilege for me to come over here, particularly escaping from the cold and dark winter of Norway to come to the sunlight, and thanks again. And I would like to especially thank my friend Professor Abdul Al Said for inviting me, and Ms. Basaid, who was also there, Khalid Al Said, and I'm also very pleased and delighted to see my friend Professor Namcho here. Thank you. So with these words, I would like to share some of my thoughts in terms of metabolic syndrome. As you know that I'm originally from Bangladesh, although I lived more than half of my lifetime in Norway. So I would like to say that most of my data I'll be presenting actually is from Bangladesh, and so I will. As probably I made a mistake, because I think that I was thinking of 30 minutes time, so it seems that it's 20 minutes time, so I will probably escape some of my slides. Please bear with me. The metabolic syndrome is not a disease, but rather a cluster of disorder, as you all already know. The question is that why we should be looking at this cluster instead of looking at individual risk factors, because we do not treat, this is the core thing, that we do not treat metabolic syndrome as a whole. We treat each of these individual symptoms, for example, blood pressure, but not as a collective. So why should we assess it? And does it equally applicable in all population? And which definition? Because we are actually dumped with a number of definitions. Its applicability to identify risk in different populations, which needs to be examined, which definition and which components, and predictability of cardiovascular disease and diabetes in different populations, especially in Asian Indians. As you know that this has been, the definitions and concept of developments has been changing, and the concept existed for more than 80 years. So there are discussions that whether this is science or it's a myth. But whatever we say it, whether it's a myth or, but it existed, and the debate still continues. The WHO in 1999, a working group of diabetes that started with this one, and IGR took it 1999, ATP3 is 2001, AAC 2003, IDF 2005, and goes on. So if you look at these definitions, for example, you see that we have different definitions, and then we have, if you look at the WHO's definition, it is in one way, the WHO definition is widely used. And then we also have IGR from 1999, and which is not very much used in this part, but in the US is very much used. ATP3 is widely used, as we know that all over everywhere. And then we also have the recently the AC that came in 2003. So it's all these definitions came in, and that also came in the IDF definition, which is mainly looking at this, for example, the central adiposity level. Given all these definitions, we get lost that which one we should be applying, and what is actually the agreement between these definitions, and whether these definitions can vary from population to population. So if you look at this, for example, if you have this, for example, this high TGs, high LDL, low LDL, and intra-abdominal adiposity, and elevated blood glucose, and inflammatory markers, and so on and so forth, it seems that it's likely to come in with diabetes, but in some cases it actually can go directly to the cardiovascular disease. And it is actually a kind of debate at this stage. I would like to draw your attention that whether it is more applicable for type 2 diabetes, or actually this metabolic syndrome is more related to cardiovascular disease. That's another discussion. Given this, and prevalence of metabolic syndrome actually seems to differ. If you look at it in the Middle East side, you see that it differs a lot from country to country. And again, the question is that whether can we compare, because all these definitions, all these prevalence rates are estimated following different definitions. So if you look at this, for example, the one that we see that, for example, this is the line of the glucose values. And then we have this insulin resistance and the metabolic syndrome, where it goes up. Failure of the beta cell failure is related to both this insulin resistance and metabolic syndrome. And then if we look at this, for example, the continuum of the cardiovascular metabolic risk, then probably we should say that, for example, if we have to live before the onset of diabetes, and then we should be looking on concentration, and which definition actually is relating to these factors of this, for example, hypertension, triglyceride, and atherosclerosis, and so on and so forth. But if you look at the WHO definitions, that it is already including diabetes as one of its component, and if we are including the diabetes as one of the component, then question debates that whether WHO is still can be applicable to identify for the people in risk to develop diabetes. Then other aspects is the for example topography of the diabetic subjects. If you look at the muscle, the fat subcontinent, so as because we know that intra-abdominal fat alone is probably actually indicating as much as metabolic syndrome as a whole. Then the question is that why we are looking at the totality, in this particularly in Asians we see this intra-abdominal fat. If you can measure it, then we'll be able to compare almost with the metabolic syndrome. And sorry. And this intra-abdominal obesity increase the risk of cardiovascular events by, if you look at this, that you see that in every components in cardiovascular disease, myocardial infarction, and all cases of deaths is increased. We also have different cutoffs for example, the abdominal obesity in the waist circumferences with men and women. But in these definitions, when you look at these definitions, actually these definitions are not taking into consideration of these differences of the waist circumferences. The insulin resistance is another factor. If you look at alone at the insulin resistance in many situations is actually have kind of better prediction of diabetes and compared to metabolic syndrome alone. And that again causes the question that whether when insulin resistance is one of the component of metabolic syndrome, then why we are taking the metabolic syndrome as a whole. But if you look, with all these debates that we have, if you look at, for example, if you look at the people, the approximately half of the patients with acute myocardial infarction half of them will have metabolic syndrome, and approximately half don't have metabolic syndrome, irrespective of the definitions we use. We also have definitions that, for example, if you look at, for example, type 2 diabetes and metabolic syndrome, and in the control population, we see that yes, it increases type 2 diabetes, of course, but metabolic syndrome will also have an increased risk. And whatever the definitions that we use, we see that increases the risk of 1.5 to 2-fold in the risk of cardiovascular events. And that also it shows that no matter all causes of mortality, and that everywhere, no matter which definitions you are using, it has some potential. The question is that whether this is larger compared to measuring insulin resistance alone, or for example central adiposity for the Asian population. If you look this paper, although this is an old one, but if you see that they have used all these definitions, WHO, NCEP, NCEP revised one, and the IDF. Metabolic syndrome in this population, and if you look the hazard ratios for cardiovascular disease, which is very important because most of the prevalence studies do not relate to the risk for they just discussed. For example, you see that the highest risk is with the IDF. With the metabolic syndrome, we find about 36%. But if you look at the hazard ratio, is about 1.5. For example, here this with this, for example, WHO definition, for example, the hazard ratio for the male is about 2.9. Now, question is that why we are measuring metabolic syndrome if it cannot predict the, for example, risk for the cardiovascular disease, for example, or diabetes. This concept of metabolic syndrome be translated into different population equally? That is another question. And here we are looking at this, for example, the white population and the black population in the United States, and looking at the metabolic syndrome is significantly associated with the prevalence of cardiovascular disease in this study. But you see that this prevalence is the white with metabolic syndrome and without metabolic syndrome in the whites, and the blacks seems to differ. So So we have started looking at it, and then you look at, for example, the metabolic syndrome in developing countries. It varies a lot, but if you look at this one, the prevalence of metabolic syndrome in Asians, here you see that we are using two measures of ATP3 and modified ATP3, and if you see, look, by measuring in the same population in Singapore, you see that differs only when you change this definition, and in the Indians you see there is a huge definition. It's a quite significant changes. If we look at this, for example, the prevalence of NCEP, metabolic syndrome, by sex and race and ethnicity, if you look at the white population, which is here, the African American, Mexicans, you see it varies greatly. A question that the definition is the definition is the same, but the population are different, and with this it differs a lot. And this is metabolic syndrome among this white UK population. The Europeans, here you have European, the South Asians, and the African Caribbeans, and you have the WHO and ATP3. You see that how this differs. And then we have done some studies. This is a study that I was involved with in Pakistan. You see that if you, depending on which definition you are applying, the WHO or the ATP3, it's a huge difference between, it's about 49, about 50% to 7.4%. And this is a study that we have done in Bangladesh. We have then seen the temporal changes of metabolic syndrome in rural Bangladesh from 1999, and this is that we have seen that, okay, it has, if you use the WHO, then they're increasing up to about 10%, whereas if you see the ATP3 is about 29%. So this alone is a, and then we try to look at the agreement between those. For example, here is the IDF. We are looking at the ATP3 and this IDF criteria with the WHO and WHO criteria with modified ATP3. If you look at these three agreements, so you will see the kappa values varies from 0.65 as low as it could be the between IDF and the modified ATP3 is as low as 0.6% to, for example, about 65 put to be as low as 20 about and 45. So the agreement between these different definitions are actually quite poor. This we have published. And then we have also looked at this in three different populations where I have worked in this: India, Bangladesh, Pakistan, and China. And we have looked at these three different definitions: WHO, ATP3, and IDF. It seems that we are with this quite different. As you can say that these numbers are very different in three populations. So then we tried to look at this, for example, those who are normal in the population. These are the normal population, and then applying on the different definitions, you see that if the normal population who don't have any diabetes or impaired glucose regulations, that you said that in that population, according to the IDF, you have about 64% will have a definition, and following ATP3, and it's also the impaired glucose regulations according to the. So you see that. But here, those with impaired glucose regulations or with those who have diabetes, according to these definitions, their prevalence of metabolic syndrome is actually lower. But however, this shows that actually the risk is increasing. I will probably skip over it. So what are the shortcomings? So if I move to what are the shortcomings of this, the WHO definition is difficult to measure the insulin sensitivity by euglycemic clamp. This is a lack of standardization of assays for microalbuminuria, and in the ATP3 definitions, cutoff for west and west line is high, and no consideration for ethnic differences taken into considerations. Whereas on the IDF definitions, low cutoff values for west line leads to the inclusion of patients with a relatively lower level of risk. So these are the problems that I'm thinking that it should be taken into consideration. And why do you think, some of the thoughts, that why do you think that these diverse prevalence of metabolic syndrome actually occurs? Probably it's because of the body structures are different. fat depositions patterns are different, and different levels of insulin resistance and lipids given the same BMI in different populations, which we saw that, for example, the insulin resistance in the same line of BMI is much higher in the Indian population compared to the white Caucasian. And for example, diverse components of cutoffs included in different definitions, because these definitions have different levels of cutoffs. Can we still apply the metabolic syndrome to for the prediction of cardiovascular disease? And underlying risk factors for this metabolic syndrome is physical inactivity, aging, and endocrine dysfunction, and genetic factors, as we have already discussed a number of times. So these things is actually putting us again to think that why do you think that we can the differences are prevalent? Because we have the evidence that these differences are present, and the body structure of the people and the risk factor for the people for both for diabetes and metabolic syndrome is also different. So now it's a question that we should, what are the take-home messages from this talk? If you look at the take-home messages, that the metabolic syndrome is a cluster of risk factors for cardiovascular disease that includes abdominal obesity, dyslipidemia, elevated blood pressure, and impaired glucose tolerance. Cardiovascular disease considered the principal clinical endpoint of the metabolic syndrome, while type 2 diabetes mellitus is considered as another important sequel. So therefore, we should probably, it's probably with this, it's right to think that, for example, this metabolic syndrome, we should have a kind of follow-up study to see the risk, whether we can predict the risk for cardiovascular disease, and this should be done in different populations. The principal determinant of the syndrome is obesity, particularly visceral obesity and abdominal obesity. And we know that visceral obesity is